We are good to go.
Hello and good evening. On behalf of Indian Society for Pediatric and Adolescent Endocrinology, we welcome you to Academics and Clinical Education series. This is series 28, and today's topic of discussion will be early life origins of later health and disease. May I now please request Dr. Ahila, President ISPAE, to take over. Ma'am, unmute yourself, ma'am.
Thank you. Sorry. Good evening, everyone. Thank you for joining us in this program. And it's a pleasure to be here today. And I'm deeply thankful to Professor Wayne Cutfield from the University of Auckland, New Zealand, for being awake in the middle of the night to give us his experience on early life origins. And it's a pleasure to have our other faculty, Dr. Krishnaveni from Holsworth Memorial Hospital, Mysore. And thanks to Dr. Tushar Godbole and Dr. Sudha Rao for mentoring both the fellows in their presentation. Thanks, Trisha and Rajali, for being a part of this program. I take this opportunity to introduce Dr. Tushar Godbole, who is a consultant pediatric endocrinologist at NASIC. He is a director of Harmony Health Club and the assistant professor at Vasantrao Pava Medical College. And he's had books written in Guy's textbook of pediatrics, IAP textbook of endocrinology, and the postgraduate textbook of pediatrics. He's got several publications, and it's a pleasure to have you here, Tushar. And I would like to invite you to take this program ahead. Thank you so much, Tushar.
So thank you so much, Dr. Ahila. So welcome again, all of you, to the ACES program hosted by ISPAE. And so we are going to have two sessions. Two eminent speakers are going to speak, and we have two case discussions by our own speakers. So the first session, expert session is by Professor Wayne Cutfield, and I take the great pleasure to introduce Professor Wayne Cutfield. He is Professor of Pediatric Endocrinology at Liggins Institute and Director of A Better Start, which is a government-funded national science challenge. He was previously the director of the Liggins Institute, which is the largest research institute in the University of Auckland. He was the former president of APES, and he has a huge number of peer-reviewed publications in journals, including the NEJM and Lancet. He is the worthy of various awards. He has been featured in the Lancet Perspective in 2015, and he has received various medals, including the Luckman Medal for Research at University of Auckland, the Howard Williams Medal for Healthcare and Research in Pediatrics by Royal Australian College of Physicians, and the Norman Wettenhall Medal for Research and Innovation by the Australian and New Zealand Society for Pediatric Endocrinology and Diabetes. His research interests include the early origins of health and diseases and the role of gut microbiome in health and diseases. So to present a part of our series, the first talk he is going to present, which is a long shadow cast, early life events and the late health effects and the diseases. So, Professor Wayne Cutfield, we welcome you, and the stage is yours.
And I'm very proud to say I'm a Wayne student.
Thank you very much, Tushar. And let me just bring up my slides. And I have to say, there's probably only one person in India who could have twisted my arm to do this in the middle of the night, and that's Ahila Ayabo, who is your current president. Now, let me just... Okay, I think you can all see, no, maybe you can't see my slides. Let me just get out of there. I'll do screen share. With you in a second. Now, sorry, I'll do screen share. And I think I am.
Yeah, it's
okay. Yeah, and you can now see my slides. Okay. what I hope to convince you of in the next 30 minutes is that early life events are important for later adult health, and that fetal health is delicately poised. And as you deviate away from an optimal in utero environment, there is an increased risk of metabolic ill health that leads to later metabolic diseases. Most of the work I'm going to show you comes from our group in Auckland, and some of the work I'm going to show you was performed by none other than your current president, Ahila Yavo, who I was very fortunate enough to work with during her PhD and to be her supervisor. Now, so what I'm going to do, and this is sort of an overview of the content, is briefly discuss the Barker hypothesis and then look at a number of common conditions in which later metabolic programming beyond birth is seen. Those born small for gestational age, preterm, post-term, maternal preeclampsia, and those firstborn. And then briefly I'll mention what is the link? Why do those early life events lead to later developmental programming? And I'll just briefly discuss potentially the role of epigenetics. Now, let me begin with a common misconception in that our health depends entirely on our genes and our lifestyle, because in fact, there is likely to be a connection between our lifestyle and the way in which our genes subsequently behaved, which is epigenetic programming. I'll come back to that later. You're all aware of the Barker hypothesis and the work that David Barker did 40 years ago. And his work was dependent upon Margaret Burnside, who was a very pedantic and thorough nurse, public health nurse, who kept very accurate records, birth and subsequent infant records around children born in a number of counties in the UK, particularly Hertfordshire. What David Barker's group showed was that with reduction in birth weight, there was an increased risk in a range of diseases. And the data I'm showing you here is, let me just make that smaller so I can see. Right. Let me move that around. Okay, it gives me better sight. Okay, an increased risk of syndrome X. And you can see as birth weight reduces, there's an increased odds ratio of syndrome X. And it's not linear. It's almost slightly exponential. The same thing is seen with diabetes mellitus, it's seen with heart disease, it's seen with stroke, and it's seen with chronic lung disease. In other words, a lot of very common non-communicable diseases. And that led David Barker to propose the Barker hypothesis, or the fetal origins hypothesis. And that is the origins of adult disease begin in utero, and that and he proposed that fetal malnutrition was the cause of small birth size, and that programmed later disease. So he didn't have any evidence of fetal malnutrition, and he made observations around birth and later adult disease and assumed that they were connected, or proposed that they were connected. Now, his observations were confirmed around the world by a number of groups, and this is just one of many studies, this one from Sweden showing the same sort of thing, that as there's a reduction in birth weight on the left, you can see that as there's a reduction in birth weight, you can see there's an increased odds ratio of type 2 diabetes, impaired glucose tolerance, impaired fasting glucose. Now, what I'm going to do is address a range of conditions as I showed you, and they all occur during fetal or very early infant life. And I'm going to focus, as I mentioned, on those born small for gestational age, preterm, post-term, firstborn children. Groups that I'm not going to have time to mention are twins, those born to mothers with severe hyperemesis, and that was work that Ahila did, those born large for gestational age, or those children born whose mothers had maternal gestational diabetes. There just simply isn't time to cover it all. But what it demonstrates, what this overview shows, is that there is sensitivity to programming where there is abnormal or impaired or malnutrition on the upper part of that picture, or overnutrition on the bottom part. And of course, these days we're dominated by issues of overnutrition. Now, in our first study of children born small for gestational age, and these were prepubertal children, we measured insulin sensitivity in these children, and lower values indicate insulin resistance. And if you look at the pink bar, you can see that those children born small for gestational age, and these were children born less than the 10th percentile. So they weren't at the extreme end of less than 2 SDs for birth weight or length, which is the more commonly used definition of SGA now. And I think it reflects that there is a continuum. This isn't an issue of just those born small for gestational age. We chose this group because they were the more severely affected. And you can see there is a dramatic 50% reduction in insulin sensitivity in those born small for gestational age. And what the study showed was that, and it helped to confirm Barker's hypothesis, in that he showed that early life events, in other words, birth size, was associated with later adult disease. And you'd assume if that was the case, you'd expect to see some evidence of that in childhood, albeit subtle evidence. And that's why we've measured insulin sensitivity, which is using the minimal model, which is a very precise tool to look at changes in insulin sensitivity. And that led me to propose the fetal salvage hypothesis, and that is the malnourished fetus receives inadequate nutrition for optimal growth. And to ensure that adequate amounts of glucose and nutrients are received to essential organs such as the brain, peripheral insulin resistance occurs in utero, and that allows for redistribution of nutrient supply within the fetus to the brain. And that leads to a permanent reduction in insulin responsiveness in skeletal muscle. Now, so that's SGA, and now switching tacks now to children born prematurely. And what I proposed there was that if children born small for gestational age have a tough time in utero, particularly in the third trimester, then very preterm children tend to be born in the third trimester early. And then they have a rather tough time in a neonatal intensive care unit. And despite the expert care they receive, it's not the same as in utero life. So it's again a period of compromise, as you see in SGA. So we measured again insulin sensitivity in a large cohort of prepubertal children, and you can see to the left the yellow bars are the preterm group. So we've got the pink bar in the middle, which is the control group. To the right is the SGA group, term SGA group, and you can see that the preterm groups, preterm SGA and preterm appropriate for gestational age, are both insulin resistant. In other words, they have a reduction in insulin sensitivity, which is similar to that you see in SGA children. And in fact, the addition of being SGA didn't appear to add to the severity of the reduction in insulin sensitivity we saw, the insulin resistance. Prematurity was the major factor in those born preterm, and it wasn't all just due to being small for preterm and small for gestational age. Now, our preterm work was extended with Sarah Matai. Again, one of your colleagues who did a PhD and a clinical fellowship with us some years ago, Cressida Hila, and she looked at those born preterm, and these were adults in their mid-30s, and this was the oldest preterm group studied. And she found that they were indeed insulin resistant. They had a marked reduction in insulin sensitivity. As you can see there on the left, their children who were born of normal birth weight to either preterm parents or term parents, they had the same insulin sensitivity values. Now, having said that, and this is where it gets really interesting for those born preterm, is that if you look at adiposity, children to the left who were born to parents who were premature had an increase in fat mass. They're the yellow bars versus the green bars in which the parents were born at term, and they had increased total fat mass and increased android fat mass, which is basically abdominal fat. And it was about 3 kilograms in the children. Now, on the right, you see that the parents who were born preterm, they indeed had increased fat mass and increased android mass, which is abdominal adiposity. And in males, this was 10 or 11 kilograms. It's quite a substantial amount of fat mass. But the important observation here is that there appears to be a second generational effect, so that prematurity not only affects that child born, but as that child grows up and becomes an adult, that adult's children, the next generation, even if they're of normal birth weight, have increased metabolic risk, in other words, increased adiposity. And we propose that that was due to epigenetic programming, because there's no other way that that could be transmitted across generations. Now, of course, if you make those observations in prematurity, the question is, well, what is it about prematurity? And what's different about those born preterm to those born small for gestational age is that there are things you can dissect and analyze because they are now ex utero, whereas in those born small for gestational age, you can't dissect out the various things that are happening in utero. And of course, in SGA children, the commonest explanation for being born small for gestational age is utero-placental insufficiency. In countries in which there is severe malnutrition, then of course it's malnutrition and poor nutrition. But across most countries, it's being born small for gestational age is due to utero-placental insufficiency. Now, what we did is we dissected out the calorie intakes of those born preterm, hour by hour, day by day, week by week, month by month for the first 3 months of life, which was a very painful, very intricate process. And what we discovered in the first 4 weeks of life is that these children had a reduction in protein intake against international recommendations at the time, and they were consuming well less than 3 grams of 3 grams per day of protein, or I should say grams per kilo per day. Now, if you look at their carbohydrate intakes, they tend to be somewhat higher, and their lipid intakes also tend to be on the sort of slightly higher side to offset the reduction in protein intake to maintain total energy intake. If we look at 4 to 12 weeks, where there is significance is that there remains low protein intake, and lipid intake and carbohydrate intakes are high, so that they have sort of disordered nutrition, predominantly manifest as low protein and for a period higher carbohydrate intake. And what we found also was that higher carbohydrate intake in the first month of life was associated with greater BMI in mid-childhood. Now, those observations were made 15 years or so ago. And of course, we know that since then, survival has improved by more than 25% in those born of low birth weight. And there have been improvements in ventilation therapies, surfactant was introduced, and TPN has become optimized with higher protein intakes. So it begs the question, with all of those changes, have those adverse metabolic changes we see, have they disappeared? And the answer is not quite. And what we find is that while insulin sensitivity has improved in red in those born preterm, it's still not normal. So there has been some improvement, but there remains, despite all of these improvements in care in those born preterm, and I'm particularly focusing on those born less than 32 weeks, notably the very low birth weight infants. You can see that they remain insulin resistant or have lower insulin sensitivities. Now, moving on to those born post-term. So I've dealt with those born small for gestational age. I've discussed those born preterm, and then we look at the other extreme from preterm, which is post-term. And these are children who are in utero longer than they would really like to be. And potentially they have a period of compromise for 1 or 2 weeks because they are in utero for about 2 weeks longer than usual. So these are children who are born 2 or more weeks beyond that expected based on date scans and other means to determine the appropriate time of delivery. Now, this was a cohort that we accessed from Sweden, and these were children who are now 16 years of age who had intricate longitudinal data, including their birth data. And in looking at this group, at those born post-term, what we find is that if we look at the post-term boys particularly, is that you can see that they are of similar height for both the boys and the girls, but in the boys, their BMIs of those born post-term was much higher, and in fact, about half of the cohort were actually obese. That wasn't seen in the girls. So that was a somewhat surprising observation, I have to say, although it's what we hypothesized. We then moved on, and this is where Ahela steps up into the midst of her PhD, in which she published a number of outstanding papers, and this was one of them about post-term children. So this was a more detailed analysis of those born post-term, because in this earlier study, all we had was auxological data. We didn't have any metabolic data on these children. And so what Ahela determined was that children born, prepubertal children born post-term had increased abdominal fat, as demonstrated by the android-gynoid ratio, and all of these android gynoid fat measurements were derived from DEXA. And so you can see there's increased basically abdominal fat as determined by DEXA, and there was a marked reduction in insulin sensitivity, even when you adjust for age and fat mass. So like the SGA group, like the preterm group, this group is insulin resistant and has an increased risk of adiposity. And in fact, the post-term group of all the groups we've studied seem to have the strongest evidence of metabolic syndrome features that we saw. So not only did they have insulin resistance, they had elevated lipids, higher leptins, low adiponectins, increased IGF-BP1, increased abdominal fat, and diminished nighttime systolic blood pressure dipping. And a diminished nighttime dip in blood pressure is a risk factor for hypertension. And that was determined by 24-hour ambulatory blood pressure monitoring. Just doing simple clinic measurements will not give you that information. Okay, so SGA, preterm, post-term, all display evidence of adverse metabolic programming. Now we move to preeclampsia, which is another relatively large group. All of these are common groups. SGA, by definition, was 10% of births. Preterm births are somewhere between 5 and 10%, about 5% for those less than 32 weeks. Post-term is about the same, 4 or 5%. Preeclampsia, similar. And you can see that in our cohort of almost 80 children that we studied, these were again prepubertal children, we found that there was similarly, and this is a really busy table, there was a reduction in insulin sensitivity, and as you would expect, an increase in HOMA-IR. Again, insulin sensitivity in all the studies I show you is measured by my modification of Bergman's minimal model to be used in children and validated in children. They also had increased diastolic blood pressure during the day as well as during the night, and the mean arterial blood pressure overnight was higher, and there was less diastolic dipping. So those are all risk factors or markers for later hypertension, and there were increased triglycerides. So again, we see yet another group in which there is an adverse in utero environment where there is adverse metabolic programming. Now, so I hope I am convincing you that developmental programming sensitivity is delicately balanced. And as you deviate away from this optimal in utero environment, the increased risks of metabolic program increase. And although the underlying cause or the underlying group is different, the pathway is similar, and it's increased adiposity, reduced insulin sensitivity or insulin resistant, increasing lipids and elevated blood pressure. Now, the groups I've discussed are common, but now let me introduce the commonest group you could ever study on the planet, and that's those who are born first, those who are firstborn. We know from a study published some years ago that firstborn children are more intelligent than secondborn children. However, if the firstborn child dies early in childhood, then the secondborn becomes more intelligent, and so on. If the secondborn child also dies early in life, then the thirdborn child becomes most intelligent. And that was pretty compelling evidence that this was due to early environment of the advantaged firstborn. Now, so we looked at those children who are firstborn, and the first thing we found is that they're taller. Firstborn children, when you correct for parents' heights and for bone age, and this was a cohort of more than 400 prepubertal children with 190 firstborns and 218 laterborns, is that if you look at the heights of children, firstborn versus secondborn versus thirdborn, they're taller. Firstborn taller than second, secondborn taller than third. Now, you'll all have exceptions to that, but when you study large groups, large populations, this is the trend that you see. And this is not insignificant. It's about 0.2 of an SD, so it's several centimeters. Now, and this is where Ahela steps in again with some more of her superb research as part of her PhD. And Ahela showed that there was a reduction in insulin sensitivity in those firstborn. And it's not a dramatic reduction, it's about a 20% reduction. Nevertheless, it's a subtle reduction in insulin sensitivity that affects a very large portion of the population, somewhere between 40 and 60, depending upon the country that you're in, 40 to 60% of the population. Now, I'm talking a lot about insulin resistance and a reduction in insulin sensitivity. And you might say, so what? That's not diabetes, and it's not. But there have been some very compelling studies in adults showing, excuse me, if you look at those who have a reduction in insulin sensitivity 10 years later, who are completely healthy, 10 years later, that group who had a reduction in insulin sensitivity or in the tertile with lowest insulin sensitivity had a dramatically increased risk of type 2 diabetes, heart disease, heart attacks, strokes, cancer, and death. So insulin resistance is a risk factor for a range of diseases and not just type 2 diabetes. And Ahela also showed higher blood pressure with daytime systolic readings and diastolic readings higher than those who were firstborn. Now, you might ask, well, why on earth does that happen? Why are firstborn children metabolically disadvantaged? And one of the reasons that we propose is, in fact, that the spiral arteries that are in pregnancy become dilated during pregnancy. And in second and subsequent pregnancies, they are more dilated. And therefore, there is greater blood flow through them and less blood flow compromise, if you like. So we propose that there, in firstborn children, there is less spiral artery blood flow than you would see in later pregnancies. But again, that's a proposal. It's an hypothesis, and it hasn't been proven. So as I keep mentioning again and again, as you deviate from an optimal in utero environment, there is an increased risk of long-term metabolic disease, whether you're born too big, too small, too sick, with hyperemesis, preeclampsia, too early, too late. Now, well, why is that? And I've mentioned several times to you that epigenetics may well be the link, which potentially links the environment to our genes. Conrad Waddington introduced the concept of epigenetics. Epigenetics is a change in gene function without a change in gene structure. Now, and in essence, what that involves, excuse me, is a number of different changes to DNA, such as DNA methylation, which there's a methyl group added, and that changes the conformation of DNA and leads to increased, if you like, tightening of the DNA spring or coil, which makes it harder for transcription factors to get in and activate genes and lead to transcription. So this is a way in which, without changing the structure of genes, you can change gene expression. And it's potentially reversible. And of course, early in life, it's a critical source during that period of methyl donors such as methionine, choline, and cofactors such as folate, B12, pyridoxal phosphate that are necessary for DNA methylation. There's some limited evidence linking changes in DNA methylation and later developmental programming. And here we look at, and this is a human study, looking at glucocorticoid receptor methylation and the amount of meat eaten, fish eaten, vegetable portions, bread portions, and potato portions, in which you can see that there are changes in glucocorticoid receptor methylation as you alter the intake of, so with increasing vegetable intake, you have increasing methylation and therefore less expression of the glucocorticoid receptor and therefore less glucocorticoid effect. Similarly, with more bread intake, then you get the reverse scene. And that leads to more glucocorticoid effect, which is less desirable in terms of ultimately metabolic influences. And this is a very interesting study by Karen Lillycrop that we're switching to mice here. It's a more intricate study in which she looked at protein restriction, which is the R column there, and looked at DNA methylation of the glucocorticoid receptor, PPAR alpha and gamma, which are important to metabolic signaling. And you can see that with protein restriction, there's a dramatic reduction versus the controls on the left in methylation of all of those genes, which lead effectively to overexpression of those genes. Because methylation basically leads to inactivation of those genes. You add folate into the diet of those protein-restricted rats, and what you find is that that process reverses. And that's evidence that nutrition can modify key metabolic genes in utero, and if you replace some of those key components, such as folate, you can reverse those changes. So in conclusion then, early life is a vulnerable window in which events, including nutrition, contribute to long-term metabolic health. Adversely programmed infants have a greater risk of obesity and metabolic disease when exposed to a later unhealthy diet and lifestyle. And it's only with that exposure to a later unhealthy diet and lifestyle, which is a mismatch phenomenon that Peter Gluckman proposed, do you see those metabolic diseases actually manifest themselves. And the role of epigenetics is really still being untangled. And while it's likely to be an important player, the evidence linking early life events with epigenetic changes leading to a specific phenotype later in life has not been well established yet. And I'd like to finish by acknowledging those who have worked with us, and particularly Ahela Yavo, who performed much of the work that some of the work that I've shown you. Thank you.
Thank you. Thank you so much, Professor Wayne. It was indeed an eye-opener for many of us. As pediatricians or pediatric endocrinologists, we have been always going through the history of a child being an SGA, but we often fail to take the history, whether the child had any prior setting of preeclampsia or an LGA baby or a post-term baby. So I think we should all be taking that history more carefully, and we should try to correlate the presence of insulin resistance with the features, the risk factors other than SGA. So thank you for that. Are there any questions in the chat box, or any of the panelists would like to ask any questions?
Can I just reply to your comment, Tusha, because I think that's a very astute observation you've made. And I've often thought that if you're an adult and you go to the doctor and they look at your heart disease risks, and they look specifically at certain things like your lipids, your family history, your activity, your alcohol intake, blah, 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 blah. But very rarely do we ever think about determining what the risks are from other early life events. And in time, I suspect there'll be a scorecard that does just what you've suggested. That includes, well, were you born early or late? Were you first or later born? Were you born post-term or not? Were you born small for gestational age? And each of these will have a likely additive effect.
So it was in one of the papers you mentioned that the firstborn is generally taller than the secondborn. But in India, I think many of us would like to disagree that the second one is taller, but the reasons are quite different in India. In India, maybe the mothers are, many of them are malnourished, and their BMI itself is very low during their first pregnancy, whereas in their second pregnancy, they're much more relaxed, and probably they have built some body mass index. So what is your opinion on that? I mean, will it affect differently with the ethnicity?
That's a very good question, Tusha. I think the only way to address that is to actually look at the impact of birth order on metabolic health in India, and would be a very good, sensible study to do. It would be an easy study to do because it's a common group. I know when we first did this work, the first group of interviews that I had were, surprise, surprise, from China, where at that time they had their their single child policy, and the concept that their policy of only having the firstborn children could have a long-term impact on the health of their children was rather frightening for them. But you make a really good point, and those are observations made in a middle-class, largely European setting. And it would be interesting to see whether you see the same thing in an Indian community, or, as you suggest, maybe it's different because, in fact, during the history of pregnancies, if you like, there is a change in BMI in Indian women. In New Zealand women, their BMIs tend to be normal, and if anything, they may slightly increase over time. But generally speaking, they start with a normal BMI.
So, Dr. Ahila, you have any comments?
Thank you so much, Wayne. And I'm really, really sorry for keeping you awake in the middle of the night. When you're
No, you're not.
And I think there's going to be an interesting lecture from Dr. Krishnaveni, who's actually used, I think, folic acid, B12, and all that in early pregnancy to see the changes in their cohorts over time. So that's a part of her work, I think. I've read through some of her publications, and I'm really waiting to listen to her also. But I know, Wayne, you're going to go to sleep. You can look at the video later. It will be uploaded on the YouTube. Thank you so much, Wayne. And we are really, really thankful for agreeing to this lecture and in the middle of the night.
Thank you.
And when you are unwell too.
And thank you for being such wonderful hosts. And look, thank you, Ahila, because a chunk of the work I presented was yours. So I'm presenting your work back to you. And a chunk of what I presented wasn't possible without you. So thank you, and thank you all.
Thank you so much, Wayne.
Thank you.
Yeah. So with this, now we move on to the next part of our session today. And I'll invite Dr. Vrushali Takrikar, who is the Pediatric Endocrinology Fellow at the B.J. Wadia Children's Hospital, Mumbai. Dr. Vrushali is going to present a very interesting case and with a really good length of follow-up. So Dr. Vrushali is going to present a case of SGA girl with, what happens as she grows up. So over to you, Dr. Vrushali.
Thank you, sir. Good evening, everyone. I would like to share with you all a case of a 12-year-old girl who presented to us right at 1 year of age with failure to thrive in absence of any obvious systemic illnesses or history of poor feeding or nutrition issues. She was born to a mother who had oligohydramnios, secondary to uteroplacental insufficiency in the 3rd trimester, and she was delivered at full term with a normal vaginal delivery and vortex presentation However, her birth weight was 1.7 kilograms, which she was small for her gestation. Other than the neonatal jaundice, which was physiological and lasted for around 2 days, her neonatal period was uneventful. She was developmentally normal at the time. Currently, she is good in studies and she is in 7th standard. She is the younger of the two siblings. She has an elder sister who's doing very well. She was on weaning diet when she first came to us, and it was adequate in calories. There were no feeding abnormalities noted. However, on examination, her weight and length both lagged behind 2 standard deviations. Head circumference was somewhat preserved, but weight for length indicated failure to thrive. The short stature was proportionate, and other than a triangular face which resembled her mother, systemic examination was largely normal. We went ahead with an initial evaluation of any possible systemic illness which can lead to failure to thrive in this age group. All the investigations done were albeit normal. We counseled her about dietary modifications and kept her on a stringent follower over the next couple of years. In the second year, her growth velocity was 12 centimeter per year, and her weight was crossing centiles. However, in the third and the fourth year, her velocity was 5.1 and 5.6 centimeters per year. Weight did improve a bit in standard deviations. However, the height was well below -2 standard deviations at 4 years of age. We re-examined the systemic screen, which was again normal. Her bone age at 5 years and 4 months was 2 years, which lagged behind significantly. She was euthyroid, eucortisol, and a clonidine stimulation test showed a peak response of 9.48 nanograms per ml at 60 minutes. We did an MRI brain, which showed a good size pituitary with a good volume. With all this in mind, we decided to initiate growth hormone therapy for this child, as she was a small for gestational age girl with pathological proportionate short stature who had failed to catch up in height at 4 years, in absence of any systemic illness, and with hormonal evaluation suggesting growth hormone insufficiency, with other evaluation being normal. So the growth hormone therapy was initiated at 5 years and 4 months at a dose of 35 micrograms per kg per day, and a periodic follow-up revealed a first-year growth velocity of 8.5 centimeters per year at 6 years and 4 months. Her height had crossed more than 2 standard deviation score, which was a good response. And over the period of next couple of years, we continued the same dose. At 8 years and 6 months, she entered puberty, and it was a rapid progression over 1 year, where at 9 years and 5 months, she was well in the Thanos stage 3 with an episode of povaginal spotting. A bone age at that time corresponded to 8 years and 10 months, with a height prediction well below mid-parental height. Hence, a GnRH analog was added to the growth hormone with a hope that it will stall puberty for some time and give us a window to help her grow better. This combination therapy was continued for 2 more years, and at 11 years, 5 months, the bone age was reassessed, which was 11 years, with an improvement in predicted adult height, which had improved from -2.5 standard deviations to -1.24 and was well within the mid-parental height range. In summary, she is now 12 years old. She is off combination therapy. We have continued growth hormone therapy for her right now, and she is on follow-up with us. This case demonstrates how a maternal environment of uteroplacental insufficiency and oligohydramnios can lead to a small baby who can ultimately fail to catch up and have adult short stature if not intervened. Moreover, an early puberty and a rapid progression of puberty seen in these SGA children can complicate our therapy to help her with her height. Hence, a combination therapy can sometimes be needed to stall puberty in such cases. As Dr. Wayne has beautifully elucidated, fetal origin of adult disease is an extension of Parker's hypothesis, and how maternal health and maternal well-being in utero can affect not only the fetus or the newborn, but it can go on very well into adulthood. There are a few definitions that we should keep in mind while dealing with a small for gestational age baby. It is worthwhile to note that 40% of small for gestational age children do not have any identifiable pathology. Incidence of adult short stature in these babies is approximately 10%. Studies have shown that a small birth weight length is much more better predictor of adult short stature compared to a small birth weight. Hence, a birth length history is also important in these cases. Frank growth hormone deficiency, although uncommon, in growth hormone insufficiency and subnormal responses to provocations test can be seen in almost 50 to 60% of these children. A younger age at initiation is definitely associated with a better response, and a mean duration can be around 7 to 8 years. There are different school of thoughts in starting growth hormone therapy, whereas in United States, they are more liberal with an earlier age of initiation. And in European countries, they prefer an age of initiation at 4 years, taking into account absolute height standard deviation score, growth velocity SDS, and reference to mid-parental height. There are many more benefits of growth hormone therapy in SGA children. Not only do they help with height, it can help with normalization of body proportion. It gives a healthier body composition with increase in lean mass and reduced fat mass. There's decrease in incidence of hypertension and improved bone mineral density. Also, there is a better psychosocial functioning because the child is growing tall. He feels better about himself. There are certain concerns about decrease in insulin sensitivity, as SGA status itself and growth hormone therapy both can worsen the insulin sensitivity. However, insulin resistance can be temporarily affected. No overt dysglycemia has been noted in the therapy, but it is prudent to monitor for dysglycemia in these children, especially if they have a history of type 2 diabetes mellitus in the family. I would like to highlight this study in which they group SGA children based on the age at which growth hormone was initiated. A bone age delay was seen in prepubertal years, as is seen in our case too. The duration of prepubertal treatment was directly proportional to a better height outcome. 1% patients did require GnRH therapy. Interesting to know is that with an earlier initiation of growth hormone therapy, the pubertal onset was also earlier. For example, in the children where growth hormone therapy was initiated between 2 to 4 years of age, the pubertal onset was 9.5 years, whereas in those children where growth hormone therapy was initiated beyond 6 years of age, pubertal onset was 11.7 years. This may complicate our treatment, as pubertal onset means a faster maturation of bones and a faster attainment of adult height, with which I come to effect of small for gestational age children on puberty. They do have a slightly early puberty with an earlier age of menarche and a faster pubertal progression. This can be explained by a mismatch between reduced prenatal weight gain and an accelerated postnatal weight gain, which augments lipogenesis and lipid storage. When do we consider combination therapy for SGA children? It is indicated when predicted adult height is less than -2.5 standard deviations at the beginning of puberty, with a mean duration for around 2 years. It has helped with a considerable improvement in height prediction, with which I would like to highlight this study, which included but was not limited to SGA girls, where predicted adult height was less than -2.5 standard deviation score. It is interesting to know that adult height surpassed predicted adult height in children who were treated with GnRH analog with a combination therapy, and adult height was less than PAH, in which it was not treated. It was treated only with growth hormone therapy. The bone age progression while on combination therapy was 6.6 years per calendar year, but it rapidly advanced as soon as the GnRH analog was stopped, and it almost doubled to 1.3 centimeters per year. 1.3 years per calendar year. It is also interesting to know that there was a 2.5-fold increase in fasting insulin levels when the children were on therapy. However, there was a normalization of fasting insulin levels when the children had completed growth hormone as well as GnRH therapy. With this, I come to end of my presentation. Thank you.
Thank you, Dr. Vrushali. That was, a very crisp and yet very detailed presentation. Two things I liked about your presentation is you had a very meticulous, data collection and a very long follow-up duration present. So if I were to ask you that, I understand that our patients often do not, follow up with us at the desired time points. I understand that she had been lost to follow up in between for some months or some years. But if given a choice, what better, things could have been done in this particular case? So if you had seen her again at, if you had an opportunity to see her on her 6th birthday or 7th birthday, would you have done something differently?
Yes, especially when she began her puberty, I would have wanted to see her bone age when she just entered her puberty. That would have given us a better window to give the combination therapy. We started it at Tanner stage 3. I would want it to be a little earlier. However, those were the pandemic years, so we couldn't get a follow-up on that at that time.
Yeah. Was the GnRH analog therapy started after she had her first spotting?
Yes, she had her spotting, but she was in Tanner stage 3. And we had given a DMPA cover before we started
Yeah.
a GnRH therapy. And
Correct.
there were no further episodes as well.
I understand it's a very tricky situation to treat such girls. You made a very, very important point that fasting insulin levels do rise. And also we have seen, many of us have seen that after putting these girls on GnRH analogs, a lot of them indeed gain a lot of weight. So what advice would you like to give them when you start these SGA girls on GnRH analog?
I think we should also stratify these patients based on their metabolic history. Not only does the GnRH analog itself worsen the insulin sensitivity along with SGA status, there is a clear predisposition to insulin resistance in children who have a strong family history of diabetes. So they should be more frequently monitored when it comes to metabolic complications. Also, a healthier lifestyle can never go wrong. So in these peripubertal years, we should always advise them to avoid junk food, avoid um, a dietary intake which is more in trans fats and less in fibers. So that can go a long way in avoiding over dysglycemia.
Your growth chart had wonderfully shown us that although the height actually peaked with therapy, but the bone age kind of advanced much rapidly. So I think that is also one of the take-home messages, that we can never predict the final height for SGA, especially girls, solely based on the bone age. So we have to be very, very cautious, because their peak growth velocity is very less as compared to normal girls. Secondly, the duration of puberty is also less as compared to the otherwise normal girls. So I think that is also one of the take-home points, that we should not rely on bone ages while predicting the final height for SGA girls. I think there was one question in the chat box that why did we start the growth hormone on the 4th birthday and not earlier? Would you like to take that?
So it is, our unit follows the European guidelines where we wait till 4 years. We take into account the absolute height SDS as well as the difference between height SDS and mid-parental height status. So that is the unit protocol.
Correct. Any comments from the panelists? Dr. Ahila.
Thank you, Tushar, for the wonderful discussion. A great presentation by Dr. Vishali and a very good analysis and guidance by Tushar. Thank you so much, both of you. That was a wonderful session.
Yeah.
Thank you.
Just one final comment. I had almost, I was almost saved because the patient was lost to follow-up. I distinctly remember one case which I had seen in 2014 or 15. He was a boy with severe SGA, failed to catch up, and at 4th birthday he was very, very short, and I had advised growth hormone therapy, but somehow the patient did not take it. And after 10 years, when the child is now around 14 years, he had come back to me with all signs of insulin resistance, and he has type 2 diabetes now. So I'm just wondering, if I had given him the growth hormone, and if I had not explained the risk of type 2 diabetes, maybe the family had accused or blamed growth hormone for the diabetes. So I think we have also have to take into consideration the risk, and tell them that regardless of giving GH, regardless of giving GnRH analog, there is an inherent risk of developing type 2 diabetes for these children.
The SAGE data actually is quite clear that they've looked at long-term data on growth hormone over a period of time, and that does not increase the risk for type 2 diabetes.
Yeah. So thank you, Dr. Vrushali, and thank you, Dr. Ahila, for this opportunity.
Thank you, Tushar, and it's your privilege to introduce Dr. Krishnamani.
Yeah.
We have
Oh,
Sudha,
sorry.
She's joined.
I
Yeah.
think I messed it up. Zalak will say.
Introduce Sudha, ma'am.
Okay. Thank you, Tushar.
Yeah, hi, good evening. It's a pleasure to introduce G.V. Krishnaveni, madam. She is a senior scientist in epidemiology research unit, CSI Holsworth Memorial Hospital. She did her MBBS from University of Mysore and then went on to do PhD from the University of Southampton, UK. And she has a large body of work over the last 2 decades and plus on the heart concept, and currently working on the stress-related early life stress factors and development of non-communicable diseases later on. We're eagerly looking forward to listening to you, madam. Now over to you.
Thank you, madam. And can you all see my slides?
Yes,
Yes, we can.
Yeah.
Okay, thank you very much for this wonderful opportunity to present our data at the ISPAE webinar. And I'm really pleased that, so this wonderful topic of early life origins is getting more attention among the clinical societies in India, because, so far we always present at epidemiological meetings and very rarely at clinical meetings. So I think this is one of the, very happening and, very relevant topics for the prevention and, management of the unprecedented rise in non-communicable diseases in India. So I'm very glad that, Professor Cutfield has already given an overview of DOHAD and, and introduced the topic and, the concept behind the early origins hypothesis. So this figure shows data from a very recent study from Chennai, which looks at the prevalence of non-communicable diseases like hypertension, diabetes, obesity, etc. The current prevalence in India. As you can see, most of the states in India show very high levels of these disorders. This figure shows diabetes, but this is the picture is similar for hypertension, obesity, and other non-communicable diseases. You can also see that the prevalence is higher in almost all the states for urban population. Even though it doesn't look so in the rural population, you can see the rates, varying ranges of rates in different states, even among rural population, indicating that there is a looming burden of NCDs even in the undernourished populations. Sorry. So as we heard before, the classical risk factors for non-communicable diseases such as obesity, sedentariness, diet, stress, etc., as well as the genes, the diabetes genes or disease genes, do not explain completely why such unprecedented rise is occurring within a generation. In a seemingly undernourished population, even though we see obesity and other not even obesity, relative obesity among urban adults, even the major portion of India, which is still rural, and the problem of undernourishment, micronutrient deficiencies, anemia, etc., are still prevailing. So in such a situation, early origins hypothesis provides a most plausible explanation. So this is a diagram from world map, which shows that both low birth weight and type 2 diabetes are higher in India. So it's the kind of paradox. So, and moreover, so one of the studies conducted by Professor Yadnik from Pune, it has been shown that the newly diagnosed type 2 diabetes adults from India, when compared to their counterparts in the UK, were younger, almost by 10 years. They had lower BMI, and they had lower mid-arm circumference, which is a proxy, which could be a proxy for lean mass. However, they had a very high levels of body fat, whether it is central body fat, subcutaneous body fat, or fat percentage, and they also had higher insulin resistance. So this was termed as the characteristic thin fat Indian phenotype, where they are muscle thin but adipose, which is giving rise to the high prevalence of insulin resistance among them, which leads to several non-communicable diseases as they age. So this is a very famous picture published in Lancet some 20 years ago, where you can see Professor Yudkin and Professor Yadnik. So, interestingly, both have exact same BMI of about 22.3. However, when you look at the fat percentage, Professor Yudkin has about 9%, whereas Professor Yadnik has about 21%. So this gives, the picture of Indian adults where, though they are seemingly thin and of low BMI, because of their high body fat, because of this thin fat phenotype, there is, higher risk of higher insulin resistance, leading to higher disease burden later in life. So, as I said, early origins of fetal origins of health and disease hypothesis proposed by Professor Barker gives a plausible explanation for such a condition that is prevalent among Indians. So, which is the fetal origins hypothesis, now called as developmental origins of health and disease, as it also involves later postnatal developmental stages also. Barker proposed that nutritional insults experienced during the critical stages of growth in utero so permanently programs the structure and physiological functions of the fetus, resulting in a phenotype that offers maximum survival at birth. However, when the fetus is faced with a mismatched nutritional environment later in life, such as postnatal overnutritional conditions, these compromised physiological functions result in several phenotypes such as hyperlipidemia, hypertension, central obesity, insulin resistance, higher stress, etc., which lead to the development of type 2 diabetes, cardiovascular diseases, and other adult diseases. So the Barker's hypothesis itself stemmed from their initial studies in Hertfordshire in UK, and you already saw Professor Cutfield showing this data, where Barker's and his colleagues show that the prevalence of several other non-communicable diseases such as metabolic syndrome, type 2 diabetes, and coronary heart diseases were significantly higher in those adults who had been born with lower birth weights. It's not necessarily small for gestational age. It's a continuous effect. As you can see, there was a continuous reduction in the prevalence of these conditions as the birth weight increased in these adults. So we have to also understand that birth weight here is not an exposure, but just a proxy for the events happening within the uterus, the fetal growth retardation, undernourishment, etc., which might be shown as lower birth weight. So after these studies in the UK, Professor Barker and Professor Caroline Fall from Southampton University in the UK aim to explore these, findings in detail in India, because as you know, Indians have one of the highest prevalence of low birth weight, under 5 malnutrition and stunting, but there is a slowly emerging increase in non-communicable disease risks. So they collaborated with several teams within India, all over India, to set up birth cohorts. These include Delhi, Pune, Mumbai, Mysore, and Vellore. So several studies have been going on, cohort studies. They're all birth cohort studies. Some of these studies are retrospective birth cohorts, mainly New Delhi birth cohort, Vellore cohort, Pune children's study, and Mysore birth records cohort. These are all retrospective birth cohort studies. So whereby the participants were recruited into the study based on the availability of birth records, whereas the Pune nutritional study and Mysore Parthanan cohort, these are the prospective studies. I'm not going in detail into the cohorts, but just to give an indication of what has been found in other cohort studies, I just give an example of the cohort studies in Pune. So Pune Children's Study was one of the first studies based on developmental origins of health and disease that was set up in India at the KM hospital under the leadership of Professor Yadne. So this study recruited children born at KM between 87 and 89. And when the children were about 4 years, they studied them for glucose and insulin concentrations and body composition and anthropometry. And the assessments were repeated again at 8 years. The study showed that, at 4 years, those children who had lower birth weights had higher glucose and insulin concentrations at 30 minutes than compared to those who had higher birth weights. See, at the time, the researchers speculated that perhaps the 30-minute insulin concentrations are an indicative of higher 30-minute insulin concentrations are an indicative of emerging insulin resistance in these children. Indeed, when these children were again studied at 8 years of age, the researchers found that those children who were born with lower birth weights had high, the 1 is the lower birth weight category and 3 is the higher birth weight category. The children who had lower birth weights had higher insulin resistance at 8 years, especially when they had higher weights at 8 years. It was like born small and grown big. That is the phenotype that was presenting with the highest risk of HOMA resistance. And the study further showed that these children who had higher insulin resistance at 8 years went on to develop higher cardiovascular risk factors at 21 years of age. So the data I'm not showing here, which gave an indication that the events happening at birth had impact even at 21 years of age. Later, to explore further about the intrauterine undernutritional effects, the Pune researchers set up the Pune Maternal Nutrition Study, where they recruited women even before they became pregnant, and they followed them up through pregnancy. They assessed them, the mothers during pregnancy, and they found that the BMI, non-pregnant BMI was less, around 18, and at pregnancy, 18 weeks and 20 weeks of pregnancy, the BMI was around 20. The women had high levels of B12 deficiency and very low incidence of GDF. And when they looked at their children, offspring at birth had lower birth weights and shorter birth length, but they had relatively higher subscapular skin fold compared to an international population, which showed that the muscle thin but adipose phenotype, which is characteristic of Indians, is present even at birth. And the Agnics and colleagues showed that lower birth weight as well as maternal B12 deficiency was associated with several cardiovascular risk factors, including higher adiposity and insulin resistance. So one of the most interesting findings from PMNS study is that those children born to mothers with lower vitamin B12 levels but higher folate levels had the highest levels of central adiposity as measured by subscapular to triceps ratio, as well as higher HOMA insulin resistance. So this study, established that it was not only the birth weight, but specific maternal nutritional deficiencies also show associations with the risk factors for non-communicable diseases, which gives more evidence for the association of developmental origins of health and disease in this risk. So based on these findings, Dr. Yadnik and colleagues proposed the hypothesis that undernourished mother in India gives birth to smaller babies, and the postnatal undernutrition and undernourishment during pregnancy continues, which as long as this cycle continues, the insulin resistance is not detrimental. However, in the event of higher postnatal overnutrition due to economic transition and urbanization, these individuals may go on to develop obesity and hyperglycemia, and probably, if it's a woman, develop gestational diabetes, leading to fetal adiposity, eyelid dysfunction, and this circle continues, which is termed nutrient-mediated teratogenesis and fuel-mediated teratogenesis occurring simultaneously in a population called, this was called as dual teratogenesis. So I'm just showing in Mysore, how economic transition of going from a rural economy to urbanized economy has led to the presence of double burden of nutrient mediated teratogenesis as well as fuel mediated teratogenesis, which is called as in several populations as double burden of malnutrition. So just to establish my point, I want to show that this is Maharaja Nalvadi Krishnaraja Vadiyar, one of the most progressive kings of Mysore, who brought in several development programs within Mysore as early as in early 1900s. So Mysore got one of the first cities to get electricity, leading to several industrial and other developmental programs, and irrigation, taking care of agriculture, etc. So my point being is that the Mysore was already in the economic transition trajectory in 1900s, in early 1900s. So the same Maharaja also placed the foundation stone for the hospital where I do my studies. This is the Holdsworth Memorial Hospital, which is one of the first centers to study early origins associations with adult diseases. So because the hospital had preserved birth records dating back to 1930s. So one of the first studies set up in the Holdsworth Memorial Hospital in collaboration with the researchers from Southampton University was the Mysore Birth Records Cohort, set up in 1993. So as part of this study, as I said, the hospital preserves birth records dating back to 1930s, and another important aspect is that most of the people who are born in this hospital still live around the hospital area. So as part of the birth record study, we surveyed an area of around 8 square kilometers around the Holsworth Memorial Hospitals, asking every household whether they were born in the HMH. And if they said yes, we took their details and, we traced their, matched their details to their birth records. And in this manner, we traced participants and invited them for a study between 1993 and 95. So the adults who were invited for the study were between 40 and 60 years of age. They had a BMI of about 23 kilograms, 23 kg by meter square. It was, more than 30 years ago. So already they had a higher BMI. So 23 is actually, supposed to be a cutoff for overweight among Indians and other Asians. So their maternal weight was about 47 kilos. And their birth weights, they were all born in 1930 to 1950, and it was more than the Pune Maternal Nutritional Study babies. So the study found, the findings of the study was similar to what was found in the Hertfordshire in UK by Professor Barker and colleagues. We showed that those adults between 40 and 60 years who had lower birth weight had higher prevalence of coronary heart diseases. Similarly, lower birth length was also associated with coronary heart diseases. But unlike what was found in the Hertfordshire, we found a different association with type 2 diabetes. We found that not the low birth weight, but it was the higher ponderal index and higher maternal weight, which was associated with higher prevalence of type 2 diabetes among these adults. So this gave us, we speculated that perhaps the, transition, the Mysore was already in an epidemiological transition mode, and these adults probably were born to mothers who were relatively, had higher body weight. So probably they had relatively higher glycemia, and probably gestational diabetes is an important determinant of adult diseases in this population. To explore this further, this is what this similar to what Dr. Yadnik had proposed: undernourished mother, urbanization leading to higher maternal glycemia, gestational diabetes, and adult type 2 diabetes in the offspring. To explore this further, we set up the Mysore Parthenon study in 1997. This is one of the first studies specifically designed to look at the long-term associations of maternal gestational diabetes along with other nutritional aspects. So we recruited about 800 women, 780, and administered oral glucose tolerance test. About 785 women completed OGTT, and we looked at several other phenotypical parameters, including anthropometry, maternal nutrient, specific nutrient status. So these women had a BMI of again 23 kilograms. However, 67% of the mothers had low vitamin D levels, and about 40% had low vitamin B12 levels. But about 6% also were diagnosed with gestational diabetes. So please note that this study was done more than 20 years ago, and it's in fact more than 25 years ago. At the time, the incidence of gestational diabetes reported was around 1% or 2%. So this was a high rate of gestational diabetes, even though these mothers also had higher rates of vitamin deficiencies. What is even more alarming was that we found that the women who were vitamin B12 deficiency were the ones who had higher BMIs, higher levels of BMI, higher incidence of gestational diabetes, and higher incidence of diabetes 5 years following their incident pregnancy, index pregnancy. So we hypothesize that in this population, not only undernourishment and undernutritional status and overnutritional status coexist within the population, but probably within the same individual, thus exposing the fetus to dual programming pathways of undernutrition and overnutrition. So of these women, about 663 babies without major congenital anomalies were followed up further as part of the Parthenon cohort studies, and 41 of these offspring were born to gestational diabetes. So the follow-up was intense, 6 months to 1 year, and we had this annual anthropometry developmental milestones at regular intervals at 5, 9, 13, and 20 years. We also had their cardiovascular assessments done, including blood pressure, glucose and insulin measurements, and body fat measurements. Their pubertal staging was done. Lifestyle indicators were measured, including physical activity, diet. Their cognitive functions were assessed. Psychological assessments were also done at several time points. During early adolescence and young adulthood, we also measure their physiological stress responses using a standardized stress test called the Trias social test, where the participants were required to perform a public speaking and mental arithmetic task in front of two adults pretending as judges, and their saliva samples were taken for their cortisol assessments, and continuous cardiac monitoring was done. So the children are now more than 20 years of age, and as you can see, we have measured a range of parameters in mothers and fathers and the children at various time points, including cardiovascular measurements, socio-demographic, pubertal stages, etc. So I'll show further, what were the associations with early life factors. So in addition to the offspring of diabetic mothers, we also identified children whose fathers had type 2 diabetes 5 years after the index pregnancy. However, this was measured only using fasting samples. And I also want to highlight that the maternal glycemic control is not known in this cohort. So coming to the results, the birth weight was the mean birth weight was 2.9, which is considerably higher than the PMNS undernourished infants. Newborns were short and light compared to the international standards. However, the subscapular skin fold thickness was relatively higher at birth and even higher than the international pop standard that we considered, showing that the thin fat phenotype proposed by the Pune maternal nutritional study is not only present at birth but continues through childhood. So we showed that low birth, no, I'm not showing the data here, but lower birth size was associated with higher fasting glucose, higher insulin resistant, blood pressure, triglycerides, and lower cognitive abilities. And also specific maternal factors like maternal vitamin D deficiency was associated by higher insulin resistance, and vitamin B12 deficiency was associated with higher stress responses. So as you can see, the offspring of born to mothers with lower B12 status had higher cortisol response to stress at different time points, this 10, 20, 30, and 40 minutes after the stressor was induced. But however, a similar association was not seen with the folate concentrations. Coming to the associations of maternal GDM and paternal diabetes with the offspring characteristics. So we found that at birth, offspring born to diabetic mothers were larger in all measurements, including weight, length, skin folds. However, a similar association was not seen with the fathers. If anything, they were smaller than the cohort mean. Just the black line here indicates the cohort mean. So even in the later childhood and adult follow-ups, we found that offspring of diabetic mothers continued to be larger, especially in how they had higher BMI or higher subcutaneous skin fold thickness. By 20 years of age, and more than 50% of offspring of diabetic mothers were either overweight or obese, and all the parameters of body adiposity was higher in them. So what, this figure shows that, red line is offspring of diabetic mothers, and green offspring of diabetic mother fathers, and black is controls. So at birth, offspring of diabetic mothers had similar subscapular skin fold as controls. However, as they aged, the difference between offspring of diabetic mothers and controls increased, and by 20 years at their age, they were considerably more adipose than the control offspring. So coming to cardiometabolic outcomes. So at 5 years, we found that offspring of diabetic mothers already had higher glucose and insulin concentrations, as shown in the Pune study. They had higher 30-minute insulin levels. At 9.5-year follow-up, we found that they had, the gray line indicates the offspring of diabetic mothers. They had higher BMI, higher systolic blood pressure, and higher insulin resistance than controls, which is the middle graph. So the offspring of diabetic fathers were no different from the control offspring. So this is the picture at 20 years, and we found that the glucose concentrations, diastolic BP, and total cholesterol levels were considerably, significantly higher in offspring of GDM mothers. And already 4 offspring were either diabetic or glucose intolerant among the GDM group of offspring, but not among controls or offspring of diabetic fathers. So the stress responses study showed that the cortisol responses were not different in offspring of diabetic mothers compared to either controls or offspring of diabetic fathers. We are still exploring this aspect, and we want to look at the gender-specific associations. Hopefully, we might be able to provide some answers in future. However, we found for the first time that the offspring of diabetic mothers show higher cardiovascular stress responses than controls at 13 years of age. Particularly in the measurements of systolic BP, cardiac output, and stroke volume. So as you can see, the black line here, the continuous line, is the offspring of diabetic mothers. They had similar cortisol or cardiac output at baseline, but after stressing, they had higher response than either offspring of diabetic fathers or controls. This is a similar picture shown with the stroke volume also. And they had lower response to systemic vascular resistance. So interestingly, the same picture was again repeated when the stress test was repeated at 20 years of age. So where the offspring of diabetic mothers show higher cardiac output response and lower systemic vascular resistance. By 20 years of age, we could also see that the offspring of diabetic fathers also exhibiting higher stress responses, particularly in relation to heart rate and stroke, but lower stroke volume responses. So we are still trying to interpret these things. Probably the lower responses with either stroke volume or systemic vascular resistance is a kind of compensatory mechanisms to reduce blood pressure. We would like to explore this further. But what is interesting is that we repeated the same stress test among 10 to 12-year-old children in Mumbai maternal nutritional project, which I am not showing here. But those children exhibited a similar association where the offspring of diabetic mothers had higher cardiac output responses and lower systemic vascular resistance response when stressed.
Ma'am, we have 2 more minutes.
Yeah, sorry, I'm coming to an end. So
Okay.
just to show that offspring of diabetic mothers also showed the lower physical activity behavior, and they were also likely to have advanced pubertal growth. So what I'm trying to say that both maternal undernutrition as shown in Pune study and maternal overnutrition as shown in Parthenon study give rise to similar phenotypical picture in offspring, which gives rise to non-communicable diseases later in life. So this more than 35 years of studies in DOHAD has now culminated in setting up an intervention study in Mysore in India. The Healthy Life Trajectories Initiative is a collaborative initiative between India, Canada, South Africa, and China in collaboration with WHO. The Indian part of the study, which is called the Early Interventions to Support Trajectories for Healthy Life in India, aims to evaluate whether a multifaceted intervention starting preconceptionally and continuing through pregnancy, infancy, and childhood reduces risk factors for non-communicable disease in the offspring. And the study is underway, and probably in the coming years, would be able to answer some of these questions conclusively. So finally, I would like to thank my collaborators, my colleagues and collaborators, the funding agencies, and most importantly, the participants of this study. Thank you very much.
Excellent. Excellent, madam.
Sorry, I'll stop sharing. Yeah.
That was a real kind of a travel through the experience of the last 30 years in relation to one of the biggest population being born even today is children born SGA. Even today we have a large percentage of babies are born SGA. Excellent. Anybody, any questions? Or I'm not able to see questions. Maybe somebody, Tushar or Jalak, can see if there are any questions for madam.
There was one question
Yes.
from Dr. Anju Varmani on whether giving B12 along with folic acid would actually reduce the burden of later metabolic disorders, because your study did show that B12 is deficient and they have higher folate and they have a higher risk for metabolic disorders in later life.
Yeah, I mean, as we all know, the folate deficiency is at least not common in urban, among urban women, pregnant women. And Dr. Yadnik has shown in several studies in Pune that, higher folate, giving folic acid without giving vitamin B12 and giving high doses of folate is one of the one of the risk factors and one of the factors triggering this epidemic of NCD in India. And they have also recently finished a preconceptional intervention study where they gave B12 along with other micronutrients, and the results are still awaited. So the healthy study that I showed, wants to look at this holistic, balanced micronutrient supplementation starting from preconception, and to see whether the balance in B12 and folate along with other micronutrients will help in reducing this risk in the future generations. So yes, definitely that could be one of the answers, but we need a conclusive proof, which we are now collecting through intervention studies.
Any other questions?
Dr. Sudha, you want to have any question about it?
No, excellent. Meaning this was an eye opener for me, and it's there in the literature which you produced so beautifully. The genetics is not yet taken over in your.
Yeah, I mean, rather than genetics, as Professor Cutfield said, we are more interested in epigenetics because we think environmental factors. Genetics is something which we are born with, which we can't change, but epigenetics can be changed. So by providing these preconceptional interventions, so we want to target the epigenetics. As you know, the epigenetic changes happen very early in the life force of a person. Even before the even at the stage of gametogenesis, not even before, even before conception, we want to target the gamete stage itself so that early epigenetic changes are taken care of, and it will have long-lasting effect on the health of the offspring. So that's
Yeah.
the basis of our preconceptional intervention.
Putting that in perspective, we do have a large number of IVF babies now.
Okay.
And they're all born, many of them are born premature as well as small, SGAs. It would be interesting to look at how those cohort behave.
Yeah,
in the
I
long
mean, as I said, we are not interested in SGA. We are looking at the continuous effect of the birth size. Even though, we are trying to increase birth size without understanding what is happening inside, physiologically, structurally. Are we just increasing fat mass without increasing, lean mass, and without taking care of epigenetic, modifications, methylation, etc. So we want to look at this holistically, not just increase birth size. So which may be detrimental because, as you see, overnutrition is also a trigger for increased NCDs. Yeah.
Dr. Sudha, actually, there is a cohort being followed up by Wayne in New Zealand on IVF babies. So they looked at both vitrified and non-vitrified overpreservation and looked at the outcomes, metabolic outcomes in both the groups.
Okay.
Okay, it will be interesting to know because we do seem to have a different metabolic milieu in Indian population.
Exactly. Yeah.
Thank you so much, madam. Thank you very
Thank
much
you.
for
Thank you, ma'am.
these excellent insights. Shall we go to the case presentation?
Thank you so much, Dr. Sudha. So we take great pleasure in welcoming Dr. Sudha Rao, who is a professor of pediatric endocrinology and one of the senior most pediatric endocrinologists in the country. She is the head of the department of at Wadia Hospital, Children's Hospital in Mumbai. And it's an honor to have Dr. Sudha Rao here with us. And she'll be guiding Dr. Trisha through her presentation. Welcome, Dr. Sudha.
Thank you so much, Dr. Ila. Thank you. So, without taking more, I would like to invite Trisha case, which is going to share with us. Trisha, please go ahead.
Yes, ma'am. A very good evening to everyone. I'm Dr. Trisha Reddy, Fellow in Pediatric Endocrinology at Manipal Hospitals, Bangalore. At the outset, I would like to thank my mentor, Dr. Sudha Rao ma'am, for my presentation. Today, I'll be discussing a case of a 6-month-old female infant from Mangalore, Karnataka, who presented to our pediatric endocrinology OPD concerned about poor growth since birth, in terms of both length and weight. There was no history suggestive of any chronic systemic illness. Starting with the birth history, antenatal history was uneventful. Baby was born at full term by a cesarean section with a birth weight of 1.5 kgs, small for gestational age. Birth length was not known. Baby cried immediately at birth. There was physiological neonatal hyperbilirubinemia requiring phototherapy for 2 days. Developmental history was normal. Baby attained all developmental milestones appropriate for age. Immunization history was up to date. Nutritional history, baby was still on exclusive breastfeeding. Family history, baby is an only child born to a non-consanguineously married couple. Family history of short stature on the paternal side is there. Mother's menarche was at 12 years of age, and father started shaving around 16 years of age. Coming to the anthropometry, this is how the child was at 6 months of age, with a weight of 5.12 kgs, a weight age of 2.5 months, a weight Z-score of minus 2.84 Z-score, length of 55 centimeters, with a length age of 1.5 months, and a length Z-score of minus 4.73 Z-score. Head circumference was 41 centimeters. Mid-parental height was 150 centimeters, which was an MPH Z-score of minus 1.36. On examination, baby had anterior fontanelle was open at level, no dysmorphism. Systemic examination was normal, and external genitalia was of the normal female type. Baby was reassured as she was only 6 months old and advised regular anthropometric assessment without fail. Follow-up between 6 months to 3 years of age looked like this on the growth chart, with not adequate catch-up growth. Anthropometry at 3 years of age. Weight was 10 kgs with a weight age of 1.4 years and a weight Z-score of minus 2.66. Height was 80 centimeters with a height age of 1.5 years and a height Z-score of minus 3.95 and a head circumference of 48 centimeters. On examination, she had no dysmorphism, no midline defects, no Turner stigmata. Systemic examination was normal, and external genitalia was of the normal female type. So, in view of failure to catch up at 3 years of chronological age, baseline investigations were done, which were all within the normal range. Hemoglobin, liver function test, creatinine and bicarb. TSH was 2.6, free T4 was 1.2, euthyroid. ATM cortisol was 16.8, eucortisol. TTGA was negative, 2.8, and a total IgA of 102, and urine routine was normal. Bone age was done, which was 2.6 years of bone age at 3 years of chronological age without a significant delay, and a karyotype was 46XX. The parents were reassured that all baseline investigations were normal and advised to continue regular 3-monthly anthropometric assessment for the next few months. So the follow-up between 3 to 3.8 years of age was like this. The child was not showing any signs of catch-up. MRI brain, which was done outside, showed a pituitary height of 2.6 millimeter and pituitary stalk was normal. Growth hormone stimulation test was done with tablet clonidine at 150 microgram per meter square. Peak growth hormone value was 14.6. IGF-1 was 52 within the normal range. Being born SGA with poor growth velocity and failure to catch up, child was started on growth hormone therapy at 3.8 years of chronological age at 0.37 mg subcutaneous daily at bedtime, which corresponds to 0.1 units per kg per day or 0.034 mg per kg per day. Clinical monitoring was done every 3 months, and IGF value was checked every 6 months and was always between plus to minus 2 Z-score. Genetic test was done as the father himself was a doctor, and it revealed no pathogenic or likely pathogenic variants. Instead, we found an additional finding of a variant with a mutation in the gene DLL3, which is a heterozygous zygosity corresponding to spondylocostal dysostosis of uncertain significance. The spondylocostal dysostosis are a heterogeneous group of axial skeletal disorders characterized by multiple segmentation defects of the vertebra, malalignment of the ribs with variable points of intercostal fusion, and often a reduction in rib number. It's associated with disproportionate short stature due to short trunk. Due to a lack of phenotype match, this DLL3 variation was classified as uncertain significance and was not corresponding to our current child. On follow-up, as they moved out of Karnataka, she was following up under the care of another doctor between 6.8 to 9.8 years of chronological age. Thyroid function test was done annually and was normal. When she came back to us at 9.8 years of chronological age, this is where she was on the growth chart. And her sexual maturity rating was A1, P1, B2, M0. We advised to do an FSH, LH, estradiol, and bone age and review back. But they reviewed back after a 6 months gap at 10.2 years of age with the following reports. FSH was 5.78, LH was 1.03, and estradiol was 32. Bone age was 11.8 years at a chronological age of 10.2 years, showing significant advancement in bone age. In view of early puberty and advanced bone age, which would finally compromise her final adult height, child was started on GnRH analog therapy with injection leuprolide acetate, 11.25 mg. On follow-up, this is how she is. She's on growth hormone therapy at 0.16 units per kg per day, subcutaneous daily at bedtime. Injection leuprolide acetate, 11.25 mg IM every 10 weeks for now. On the growth chart, this is where she is currently. Moving on to the discussion, I'll be briefly going on to the international consensus guidelines on SGA, etiology and management from infancy to early adulthood, published in Endocrine Society in 2023. Definitions: SGA means a birth weight and or a birth length below -2 SDS for gestational age. Neonates born SGA can be majorly classified into 3 groups: SGA for weight, SGA for length, and SGA for both weight and length. IUGR versus SGA. IUGR is most oftenly due to a pathological cause, whereas SGA, there's no pathology. But there is about 10% of them which overlap. As per the definition, IUGR is an inappropriate gain in estimated fetal weight and abdominal circumference, irrespective of the size at birth. Whereas SGA is a birth weight and or length below -2 SDS. Appearance, IUGR babies always appear malnourished, whereas SGA babies do not appear malnourished. Ultrasound measurement, to term it as IUGR, at least based on 2 ultrasound measurements, whereas SG is a single point measurement of weight or length at birth. Birth anthropometry, IUGR babies are sometimes low birth weight, but not always. SGA babies always have a low birth weight or a low birth length or both. Pathological cause, IUGR is almost always due to a pathological cause, and SGA is not always due to a pathological cause. Coming to the terms catch-up growth. Catch-up growth in length or height is defined as a growth rate in centimeters per year more than 0 z-score. That is, more than the median for chronological age and gender. Appropriate catch-up growth in length or height is defined as growing into the normal height range, taking into account the mid-parental height and the target height. Term SGAs usually catch up by 2 years of age. This is true for at least 85% of them. Preterm SGAs usually catch up by 4 years of age. 90% of the SGA babies have catch-up growth, whereas 10% of them have growth failure and end up having short stature. Etiology of SGA is definitely multifactorial. They include perinatal factors like prematurity and infection, maternal factors like maternal height, smoking, pre-pregnancy weight, gestational weight gain, gestational hypertension, gestational diabetes, overweight, obesity, lactation, anxiety, and parity, and fetal or neonatal factors like genetic defects and nutrition. Consequences of being born SGA. I'll be talking under 3 broad terms: newborn period, infancy period, and childhood. In the newborn period, we're concerned of 2 major things: hypoglycemia and hypothermia. Hypoglycemia occurs in 1/3 of the SGA babies experience hypoglycemia. The causes being low glycogen stores, low free fatty acids and ketones, which are suggestive of low fat stores. Hypothermia, the causes being excess heat loss because of the increased body surface area due to the relatively large head, excess transdermal insensible heat loss, and lesser subcutaneous fat and reduced fat stores. In infancy, SGA babies catch up in weight and length is highest between 3 to 6 months of age, with a higher catch up in weight than in the length. The key risk factor for developing metabolic diseases later on in life is not the birth size, but the accelerated postnatal growth. An increase in fat mass occurs earlier and is much more than the muscle mass increase. Healthy catch-up growth is when there's a gain in weight, length, and lean body mass all occurs parallelly. In childhood and adolescence, first in terms of growth, there are various factors that contribute to the growth failure. They include signaling pathways in the skeletal development, epigenetic regulation, certain amount of growth hormone resistance, the gut microbiota, and the hypothalamic programming. They all have effects on the GH-IGF-1 axis and the growth plate. Puberty. Puberty starts slightly early and there is accelerated pubertal progression. Age at menarche is approximately 5 to 6 months earlier than the AGA babies. Premature adrenarche can occur in SGA girls who had a rapid weight gain during early childhood. There is also an increased risk of PCOS. Studies have found that there was no difference between the FSH, LH, testosterone, and inhibin B among AGA and SGA boys and men, suggesting that being born SGA does not affect the Sertoli and the Leydig cell function. Thyroid function. Preterm SGA babies have a higher TSH level and a risk of transient hypothyroidism. BMD. Bone mineral density is on an average lower, but within the normal range. Metabolic consequences. Insulin resistance occurs right from birth and is detected by 1 to 4 years of age, which is sharply amplified in those with a rapid weight gain and accelerated fat mass accumulation. There are certain risk factors for developing metabolic consequences. They include being overweight, obesity, ethnicity, and family history. Evaluation: weight, length, head circumference, and weight for length or BMI must be monitored 3 monthly in the first year of life, 6 monthly in the second year of life, and thereafter annually. When a child being born SGA has persistent short stature, which is defined as less than minus 2.5 z-score by 2 years of age or less than minus 2 z-score by 3 to 4 years of age, without signs of catch-up growth in the previous 6 months, will require evaluation. When there are signs of secondary growth disorder, conditions such as hypothyroidism, celiac disease, GH-IGF-1 axis disturbance, or chronic diseases should be evaluated. A skeletal survey is useful to obtain a specific diagnosis of skeletal dysplasia in the
Trisha,
case of this. Yes,
is it
ma'am.
okay if can you go back to the previous slide, please?
Yes, ma'am.
So this child which you had presented had
Yes,
a
ma'am.
Z-score which was quite low even at 2 years of age.
2 years of
Was
age.
there a
Yes,
reason
ma'am.
on why you did not intervene at 2 years? It's almost similar to the
Ma'am,
question Zalak had asked in the previous presentation.
yes, ma'am. Same, ma'am. The hospital protocol, and also these are the latest guidelines. This is published now, ma'am. And also, this is what we follow in our unit. Up to 4 years, we wait, ma'am.
Oh, so you don't start at 2 years, even if there are
We
significant,
keep,
if they don't have catch-up growth by, you had mentioned that the catch-up growth happens
yes,
by 2 years. Actually, look at
yes.
international data, it usually catches up by 6 months.
Mm.
And 85% catch up by 1 year, and beyond 1 year, very, very rarely do children catch up on that
Yes,
length.
ma'am.
So this child was significantly small to have presented to you at 6 months of age.
Yes, ma'am.
So would you, if you were given a chance to have another child like this, would you
Yes,
consider
ma'am.
starting early or would you still wait till 4 years of age?
Probably will consider definitely starting earlier, ma'am.
Because I thought you were presenting that. So Dr. Sudha,
Yes.
do you have any question?
Malnutrition and like Dr. He said, how increase size is something of a challenge postnatally also. And we do have a large number of extrauterine growth restriction in these babies are born SGA. The cutoffs are based on some epidemiological data, surely, but that must be the population-based cutoffs possibly. The guidelines hardly has a representation from our Indian population. So it's very important for us to see as to how our children grow and with good nutrition, even though you say nutritional intervention and you speak of ruling out systemic illnesses, that needs to be multiple times seen. Of course, the follow-up is important. And we all know that there are underlying genetic disorders which can be present as SGA, the cause of SGA. So checking them out for a growth, what is it called, modulation or growth augmentation with growth hormone earlier is a story which is coming, I think, from the West. Maybe we could, of course, it's like, if it was like you say, you had a minus 4 point something SD. I think your SD at the beginning was minus 4. That's too low. Maybe that child really would need a more closer kind of look to whether it's improving or not. But it did improve when the child came back to you at 3 years. From minus 4, it came down to some minus 3.5. So there was a change of almost just 0.5 over a period of time. But yes, it's always debatable. Yeah.
Yes, ma'am. Also, the parents were shorter side, so MPH Z-score was also minus 1.36. So if we take that into account, then the SD score is around minus 2.9, ma'am. Take into the account. Yes.
And having said that, the largest use of growth hormone in our country after GHD, maybe GHD is delayed in diagnosis. SGS for some reason get more of, what is your opinion, Dr. Aila? They get more of growth hormone therapy as compared to say the GHD conditions, So GHD do not come at 2 years. At least this SGS, they have a rider at the time of birth and people follow them up more closely like this protocol and they get picked up earlier also. So the largest use of growth hormone is also in SGA, because our population percentage of low birth weight babies itself is 30% of our babies are born small at birth.
Probably the spectrum seen as
What do you
different in
think?
different parts of the country. In Tamil Nadu, I mean, in Coimbatore anyway, where I see most of the referrals are for regular follow-up on a growth chart and growth failure rather than only SGA. SGS, because we get free growth hormone from the government. SGA may or may not get it always. The sanctioning by the government is not easily available for them. But for children from affordable families, yes. But for the free growth hormone in the government, it usually goes to those children with growth hormone deficiency.
Yes. And do you always do genetics, Trisha? Do you always do genetics?
No, not always, ma'am.
Babies
The
who
thing,
are born,
not always, ma'am. Actually, the father himself was a doctor, so he insisted as well. Yes.
Spondylocostal dysostosis, they have a very specific face. Their nose is totally flat. Their fingers are different.
Yes,
I mean, as you said, I think the father's pressure was a bit too much.
Yeah,
towards the genetics.
that's true. Yes. Shall I move forward?
Yes,
ma'am?
please. Thank you.
Last couple of slides. So GH stimulation test is not required in all short children born SGA, but they do remain part of the comprehensive evaluation of those suspected of GHD. If there are any dysmorphic features, then we can consider genetic testing. The trio whole exome sequencing increases the diagnostic yield. Growth hormone therapy. SGA is the second most common indication for growth hormone therapy after GHD. GH therapy can be initiated as early as 2 years of age in those without a catch-up growth. Recommendation is that growth hormone therapy is recommended in children born SGA with persistent short stature at an age after which catch-up growth is unlikely, around 3 to 4 years of age, provided other causes of short stature have been ruled out. These are the various recommendations based on the country. Indications for growth hormone treatment in the United States, Europe, and Japan. Earliest is in the United States, as early as 2 years of age. Dose for growth hormone therapy in SGA children is 0.033 to 0.067 mg per kg per day, which corresponds to 0.1 to 0.2 units per kg per day. Effects of growth hormone therapy on growth: it induces catch-up growth and improves the final adult height. On puberty, does not influence the pubertal onset or duration. Glucose metabolism, it definitely further decreases the insulin sensitivity because of its antagonistic action. Body composition, it decreases the fat mass and increases the lean body mass. Blood pressure and lipid profile. Blood pressure, total cholesterol, and LDL levels decrease. Thyroid function, it lowers the free T4 levels because of an increased conversion to free T3. BMD, whole body and lumbar spine bone mineral density increases. Clinical management during GH therapy. IGF-1. Measure IGF-1 within 3 to 6 months of initiating GH therapy and thereafter at least annually. Aim is to maintain the IGF-1 between plus to minus 2 Z-score. During GH therapy, annual assessment of TSH and free T4 is recommended. Routine evaluation of metabolic parameters such as fasting blood sugar, insulin, A1C, lipid profile is only recommended for children born SGA treated with GH with other risk factors such as being overweight, obese, or having a positive family history. When do we stop GH therapy? When they attain near final adult height, which is defined as a growth rate of less than 1 centimeter in 6 months, in a combination with closed epiphysis on bone age. GnRH analog therapy. Indication: when GH treated SGA children are still short at the onset of puberty with an expected short adult height of less than minus 2.5 STS. That's an indication to start GnRH analog therapy.
Just to come in here, this
Yes.
statement itself is a bit, what is it called, restrictive or permissive, I may say, maybe permissive. In your case, you had started GnRH analog when the child was about 10 years, 2 months, right?
Yes, ma'am.
And the reason you mentioned was the advanced bone age.
She also had onset of puberty. She had Tanner stage 2 breast, ma'am.
Yeah. So onset of puberty at 10 years, 2 months.
Yes.
And a bone age of 11 years, 8 months. Will that meaning, of course, anybody who's on GH, 10 years, 2 months is definitely not an early onset of puberty. And then if you say that bone age was 11 years, 8 months, the degree of advancement, and we know the prediction is really very poor in these children. So how do you give every child who's on the GnRH analog therapy in this case
Yes,
could
ma'am.
have some future issues which you need to be monitoring and looking at?
It's on the weight gain and also the bone mineral density. But this child would be definitely beneficial with GnRH analog therapy because of the advanced bone age, and she was still less than minus 2.5 Z score. So she definitely would be beneficial if we had added the GnRH analog therapy.
There's a huge debate on, as Dr. Sudha mentioned, the cost-benefit ratio of using GnRH analog and growth hormone therapy in such an advanced age. That's been very, very individualized, probably because this family had pushed you for it and you could have given. Otherwise, you could have a target height which is acceptable socially, which would what you would aim for rather than a Z score you will look at. So if you look at severe growth hormone deficiency, where there is difficulty in procuring growth hormone, even in the US, the target height is 150 for girls and 160 for boys. In India, we can actually have an acceptable social height so that it's a social disease rather than a disease for this child. So I think, as Dr. Sudha mentioned, this would be debatable on how much height this child would get by just adding GnRH analog to the growth hormone and growth hormone at such an advanced bone age. Because if you look at cost-benefit ratio, it's definitely going to be very, very restrictive.
And could that have any future counseling regarding future which you may need to do? You said bone mineral density 1. Could there be anything related to menstrual irregularity, PCOS, any of those?
Yes, ma'am.
there
Already
an
being
increased risk
born
in
SGA. Yes, already being born SGA, they're already at an increased risk of PCOS because of the insulin resistance. So yes, there is definitely a risk, ma'am.
No, I think the question is,
Mhm.
this child is born SGA, so they already have a risk for PCOS, and if they have premature adrenarche specifically, they will have even more higher risk for PCOS. But would adding growth hormone increase the risk?
Yes, ma'am.
Or
Because
adding GnRH analog therapy increase the risk?
yes, ma'am. Growth hormone will increase the risk because it further decreases the insulin sensitivity.
It will not. It won't interfere with the risk for polycystic ovarian disease. It's more to do with their nutrition and their body physique, rather than adding. Both these drugs will not interfere with the risk for PCOS.
Okay, ma'am. The insulin
basic,
resistance.
the basic pathology is this androgen excess. No? So GnRH does not decrease the androgens in any way.
No.
So yeah. Okay.
Yeah,
And
we are just nearing the end of
That's done.
yes,
Any
ma'am.
more slides? Yeah.
That's it, ma'am. With this, I conclude. This is the final flowchart as to how we approach a child with SGA. And with this, I conclude my presentation. Thank you, everyone, for this opportunity.
Excellent, Trisha. That was a very nice presentation.
You did
Excellent.
very, very well.
Thank you so much.
The presentation was
Thank you. Thank you, everyone, for this opportunity of having this unique topic being discussed through ISPAE ACES. It was a
Ma'am, we
pleasure
have
being
a
part
question.
of it. Thank you. Yeah.
Sorry, we have a question in the bone age is 10% at least on both sides of chronological age. Should GnRH analog be advisable at stage B2?
I think we are actually questioned Trisha on adding the GnRH analog at such an advanced bone age. It's definitely what Dr. Atul Gupta is asking as a relevant question. I think their starting was based on the family demand rather than. I'm sure that the team would have advised them that they are not going to get too much of benefit from adding these drugs. But because that family had dad was a parent, parent was a doctor, they must have pushed the team into prescribing it for them. Nisha, is that right?
Yes, ma'am.
Yeah.
Definitely.
I'm sure your team would have
Yes.
definitely advised them against.
Yes, ma'am.
Yeah.
There's one more
Anything
question.
else, Ella?
Oh, yeah. Okay.
Okay. Okay, thank you. Thank you very much.
Thank you, Dr. Krishnaveni. Thank you so much. And Zalak, it's your turn.
Thank you, Ahila ma'am, for coming up with wonderful ideas every time for the ISPAE ACES meeting. On behalf of Team ISPAE, I would like to convey our appreciation for the contribution of our guest speakers today. Thank you, Professor Wayne Cutfield, for talking from New Zealand at such an odd hour. We enjoyed your talk. Thank you, Dr. Krishnaveni ma'am, for taking us to the Indian perspective of early life programming of adult disease. Your work has been commendable and very inspiring. We thank our mentors today, Dr. Tushar, our ever-smiling young dynamic pediatric endocrinologist, and thank you, Dr. Sudha Rao ma'am, our senior pediatric endocrinologist with academic excellence and competency. Thank you, Dr. Vrushali and Dr. Trisha, for wonderful cases. Thank you all delegates for attending today. The next ISPAE ACES meeting will be in September. Do join us. Thank you, RX event team, for the smooth proceedings of the meeting. Thank you, everyone. Good night.
Thank you.
Thank you.
Thank you,
Bye,
Dr.
bye.
Sudha, Dr. Krishnaveni,
Thank you.
and everyone.
We
Thank
take a
you so
Thank
much.
you, Ayla.
Trisha and Vrushali, best of luck. And
A
thanks.
photo
Zalak.
before we leave. Vrushali, please switch on the video. Yes, thank you.
Thank you so much.
Thank you. Thank you. Bye-bye.
night.
Bye.
Bye.
Good night.
Thank you, ma'am.